With the mind up on lung volumes and capacities, we'll look at the various static lung volumes and capacities and provide typical values for each. We'll explain the facts that affect various lung volumes and capacities, and we look at FEV1, FVC, FEV1, FVC ratios, and their role in differentiating obstructive and restrictive pulmonary defects too. And finally, the volume time curves and flow volume loops to identify obstructive and restrictive pulmonary defects. Alright, so let's just go straight to the measurements. Tidal volume. Let's give a typical value like 500 mils. So what is tidal volume? Volume is the amount of air inhaled or exhaled in one breath during relaxed, quiet breathing. So that's tidal volume. The amount of air that is inhaled or exhaled in one breath during relaxed, quiet breathing. And with the inspiratory reserve volume, let's give a typical value like 3,000 mils. It has to do with the amount of air in excess of the tidal inspiration that can be inhaled with maximum effort. With expiratory reserve volume, that is the amount of air in excess of tidal expiration that can be exhaled with maximum effort. And the residual volume, let's give for both expiratory reserve volume and residual volume 1200 mils. So with the residual volume is the amount of air remaining in the lungs even after maximum expiration, and it gives alveoli inflated between breaths and mixed with fresh air on the next inspiration. And so those are the four volumes: tidal volume, inspiratory reserve volume, expiratory reserve volume, and the residual volume. Okay, so tidal volume, during amount of air inhaled or exhaled in one breath during relaxed quiet breathing. And inspiratory reserve volume, amount of air in excess of the tidal inspiration that can be exhaled, that can be inhaled with maximum effort. And expiratory reserve volume, amount of air in excess of tidal expiration that can be exhaled with maximum effort. A residual volume, amount of air remaining in the lungs even after maximum expiration, which keeps the alveoli inflated between the breaths and mixes with fresh air on the next inspiration. So the capacities to also for the vital capacity, let's give a typical value of 4,700 mils is the amount of air that can be exhaled with maximum effort after maximum inspiration. So that is the vital capacity. So it's expiratory reserve volume plus the tidal volume plus the inspiratory reserve volume. So vital capacity has to do with two or more consecutive volumes added together. So it's used to assess the strength of thoracic muscle as well as pulmonary function. And with the inspiratory capacity, the core value of 3,500 mils is the maximum amount of air that can be inhaled after normal tidal expiration. So that is the tidal volume plus inspiratory reserve volume. That is the inspiratory capacity, maximum amount of air that can be inhaled after normal tidal expiration. And with the functional residual capacity is the amount of air remaining in the lungs after a normal tidal expiration. Okay. And that is the residual volume plus the expiratory reserve volume. And total lung capacity of 5,900 mils. I think of functional residual capacity 2,400 mils being the residual volume plus the expiratory reserve volume. A total lung capacity is the maximum amount of air the lung can contain. So that's a combination of both the residual volume and the vital capacity. Okay. So you realize that the there are four volumes for capacities. Volumes being the tidal volume, amount of air inspired or expired in quiet breathing, then inspiratory reserve volume, that is after um, tidal inspiration, the maximum amount of air that could be inhaled, and the expiratory reserve volume is after tidal expiration, the amount of air that could be exhaled. Residual volume remains even um, even after maximum expiration, and it keeps the alveoli inflated even between the breaths and mixed with fresh air on the side. And then the um, tidal total lung capacity has to do with everything, the amount of air the lungs can contain, which is the residual volume plus vital capacity, and the vital capacity being the um, amount of air that can be exhaled with maximum effort after maximum inspiration, which combines all the other three volumes: inspiratory reserve volume, tidal volume, and expiratory reserve volume. And also with the residual functional residual capacity being amount of air remaining in the lungs after normal tidal expiration, the combination of the expiratory reserve volume and the residual volume. All right, so lung volume, one of the four primary or non-overlapping divisions of the total lung capacity, um, is why you can say lung volume. Right? So lung volume is just one of the four primary overlapping subdivisions also of the total lung capacity. So the four static lung volumes are like tidal volume, inspiratory reserve volume, expiratory reserve volume, and the residual volume. And the lung capacities, a capacity refers to measurements which comprise of more than one volume, so two or more. And there are four lung capacities, like I talked about: the total lung capacity, vital capacity, inspiratory capacity, and functional residual capacity. Alright, so with the factors affecting lung volumes or capacities, the main factors influencing lung volumes are age, sex, height, and ethnicity. And with sex, generally the volumes are greater in males than in females, and with age, extremes of age have lower lung volumes. Height, taller people have larger lung volumes, and ethnicity, generally blacks have lower lung volumes than Caucasians. And the ethnic differences may be due to factors that affect lung development, like geographical location, levels of physical activity, childhood, and diet. So lung volumes are greater in males than females. Extremes of age have lower lung volumes, like the neonates and the elderly. Height, taller people have larger lung volumes, and ethnicity too. Alright, so with altitude, the bigger lung volumes in people living in regions of high altitude, there's a physiological adaptation, and with the weight or BMI, obesity leads to a reduction in all static lung volumes except the tidal volume. And the mechanism of reduction in lung volumes in obese is increased intra-abdominal pressure, and worst affected is respiratory reserve volume, and therefore the functional residual capacity. Posture also affects lung volumes or capacities. The functional residual capacity is reduced in the supine position compared to upright position. The mechanism behind it is that the abdominal content is displacing the diaphragm. Disease states like restrictive and obstructive pulmonary disorders could also affect lung volumes and capacities. So with the measurement of lung volumes and capacities, spirometry can measure all lung volumes except the residual volume, and all lung capacities that has the residual volume as a component cannot be measured by spirometry. So the techniques for measuring lung residual volume and functional um, residual capacity or total lung capacity is the helium dilution method, um, nitrogen washout method, the body box plethysmography, which applies the Boyle's law. Okay, so those are the three that we use since spirometry cannot measure residual volume. Dilution, helium dilution method, or nitrogen washout method, or the body box plethysmography. That's what we use. Alright, so let's take them one by one again. Tidal volume, or VT. So it's the volume of gas inspired or expired with each normal breath, and about 500 to 600 mils in an average 60 to 70 kilograms, and is estimated to be 6 to 10 mils per kilogram in children, and increases with increasing activity. So tidal volume has to do with volume of gas inspired or expired with each breath during resting or quiet breathing states. Expiratory reserve volume, the extra maximum volume of gas that can be forcefully expired at the end of spontaneous expiration. So, or tidal expiration, the volume of air that could be forcefully expired. And reflects thoracic and abdominal muscle strength, thoracic mobility, and the balance of elastic forces that determine the expiratory level. It's markedly reduced with obesity, because of reduced functional residual capacity in obesity. But the inspiratory reserve volume is the extra maximum um, volume of gas that can be inhaled at the end of normal spontaneous inspiration, and it's the reserve available for increase in tidal volume. And in mid position, the expiratory level does not change. Inspiratory reserve volume decreases with as the tidal volume increases. So mid position, the end expiratory level does not change the inspiratory reserve volume. So remember that it's decreases, the inspiratory reserve volume decreases as tidal volume increases. So with the residual volume is the volume of gas that remains in the lungs even after maximal expiration, and with intact lungs and thorax is the minimum volume of air that the lungs can contain and cannot be measured by spirometry, like I said. So vital capacity has with the maximum volume of gas that can be exhaled after maximum inspiration, and it combines inspiratory reserve volume, tidal volume, and expiratory reserve volume. That is, with the exception of the residual functional residual capacity. So in restrictive lung disease, there is reduced total lung capacity, reduced vital capacity. Functional residual capacity has to do with the volume of air remaining in the lungs at the end of normal tidal expiration, and it's a combination of the expiratory reserve volume and the residual volume. And it represents a balance between the inward recoil of the elastic lungs and the outward recoil of the chest wall. The functional residual capacity cannot be measured by spirometry, so it falls with lying supine, and in obesity, pregnancy, intra-abdominal tumors, and during anesthesia. My functional residual capacity does not significantly reduce with aging. And so the importance of this particular capacity, the functional residual capacity, that during apnea is the reservoir to supply oxygen to the blood, and if it falls below a certain volume, the closing capacity, the airway closure occurs, leading to shunt. And why obese patients desaturate faster during apnea is that there is reduced functional residual capacity. That's the oxygen stores, and increased metabolic rate. That's oxygen utilization. For example, say a 25-year-old has an expiratory reserve volume of 1.3 liters and a residual volume of 1.2 liters, and his oxygen consumption is at a rate of 250 mils per minute. Estimate how long it would take for him to deplete all his oxygen stores during apnea. That is, if he was breathing in room air before he became apneic, and also if there's 100% oxygen before he became apneic. Okay, so this is very simple. So with the given data, the expiratory reserve volume is 1.3 liters and the residual volume is 1.2 liters, and the oxygen consumption rate is 250 mils per minute. That is around 0.25 liters per minute. So when you consider the two conditions, in room air before apnea, the oxygen is 21% and 100% of oxygen. That is for the second condition. So let's take it step by step. So when you calculate the functional residual capacity, it's the volume of air remaining in the lungs even after normal respiration, like I said, and it's course comprises several volumes. So the expiratory reserve volume and the residual volume, which is 1.3 liters plus 1.2 liters, which makes 2.5 liters. So the next step that you can think you have to go on is the oxygen content in each condition. So with room air, 21%. So the fraction of oxygen in room air times the oxygen available in the lungs. So 21%, which is 0.21 times the 2.5 liters, and you get 0.525 liters or 525 mils. Now let's move on to the next, which is 100% oxygen. The fraction of oxygen is 100%, and the oxygen available in the lungs would just be the same. So 2.5 liters by 100%, which is 1, and you still get a 2.5 liters or 2,500 mils. Now the time to deplete oxygen stores is the time to use up the available oxygen, and that is time is equal to available oxygen over oxygen consumption rate. So the available oxygen right now, for room air will be 0.525 liters all over 0.25 liters per minute. So that is the oxygen consumption rate, and you get 2.1 minutes. And with 100% oxygen, the time will be the available oxygen 2.5 liters over the oxygen consumption rate, which is 0.25 liters per minute, and you still get 10 minutes. So in room air before apnea, at a 21% oxygen, it's 2.1 minutes, and in 100% oxygen before apnea, that is 10 minutes. So this question is quite simple, right? Now, a quick recap on inspiratory capacity, which is the maximum volume of air that can be inhaled from a normal end expiration. So it's the tidal volume plus the inspiratory reserve volume. And what is the physiologic significance of inspiratory capacity? With the physiologic significance of inspiratory capacity, let's go back to the basics. It's the maximum amount of air that a person can inhale even after normal expiration. Is the sum of the tidal volume and inspiratory reserve volume, and that is the volume of air that is inspired or expired during normal quiet breathing for tidal volume, which is around 500 mils in an adult, and inspiratory reserve volume, which is additional air that can be inhaled even after normal tidal inspiration. That's about 1,000 ml in an adult. The normal inspiratory capacity is around 3.5 liters in a healthy adult. So the physiological significance of inspiratory capacity is actually an indicator of lung function and pulmonary reserve. Is also plays a role in oxygenation and gas exchange, and also in exercise physiology, with clinical significance in respiratory diseases too, and also in preoperative and ventilator management. And finally, it has a role to play in deep breathing and preventing um, atelectasis. So the when it comes to respiratory capacity being an indicator of pulmonary function, lung function, and pulmonary reserve, it represents the maximum amount of lungs to um, maximum ability of the lungs to take in the air, which is very important in assessing the lung capacity and function. So decreasing respiratory capacity indicates restrictive lung diseases like pulmonary fibrosis, or conditions that limit lung expansion. And respiratory capacity is crucial for oxygen delivery, as it determines the volume of fresh air reaching the alveoli. A higher respiratory capacity improves alveolar ventilation, ensuring better oxygenation of the blood and removal of carbon dioxide. And when it comes to the role in exercise physiology, during exercise, respiratory capacity increases to meet the higher oxygen demand. Athletes and individuals with good lung condition have a higher respiratory capacity, allowing them to maintain endurance and reduce fatigue. And when it comes to the significance of respiratory diseases, in obstructive lung diseases like COPD and asthma, the respiratory capacity is often decreased due to air trapping and increased residual volume, and reducing respiratory capacity limits exercise tolerance and contributes to a breathlessness. And restrictive pulmonary disease, like pulmonary fibrosis, obesity related hypoventilation, it's mildly reduced due to decreased lung compliance and stiff lungs. And in pre-operative and ventilator management, respiratory capacity is measured preoperatively to prevent the risk of post-operative pulmonary complications, and it's also important in ventilator settings to optimize tidal volume and ensure adequate oxygenation. So still, and lastly, on the physiological rules of respiratory capacity, plays a role in deep breathing and preventing atelectasis. So atelectasis has to do with lung collapse. So deep inspiration, with that is increasing respiratory capacity, helps in preventing alveolar collapse, which is atelectasis, and especially after surgery or prolonged immobility. And the techniques used are incentive spirometry, which uses respiratory capacity to encourage deep breathing in hospitalized patients. So respiratory capacity actually plays a regulatory, a vital role in the respiratory physiology, exercise adaptation, and clinical setting. It's a key indicator of lung function, helps in assessing pulmonary health, guiding treatment, and also preventing complications such as atelectasis and hypoxemia. All right. So total lung capacity is the volume of air contained in the lungs at the end of maximal inspiration, and is a sum of all the four lung volumes. It cannot be measured by spirometry, remember, because of the residual volume. And total lung capacity is reduced in restrictive lung disease. Okay, so there's another capacity, which is or closing capacity of volume. Basically refers to lung volume below which small airways begin to close. So that's the closing capacity or the closing volume. So the residual volume trapped in the alveoli is secondary to closure of the small airway at the end of expiration. So the closing capacity increases with age and may contribute to decrease in arterial pressure or partial pressure of oxygen with age. And the closing capacity actually doesn't change significantly with posture. The relationship between the closing capacity and the functional residual capacity depends on posture, and at around age 45, the closing capacity equals the functional reserve residual capacity in supine position. Around 70 to 75 years, the closing capacity equals the functional residual capacity in the upright position. So now let's look at some dynamic lung volumes like FEV1, and then look at the correlation with tidal volume and the ratios involved. So FEV1 is the forced expiratory volume in the first second. There's amount of air you can force from your lungs in 1 second after maximum inhalation. So it's important in grading the severity of lung disease like airway obstruction, and is reduced in many lung disorders. Um, so forced vital capacity has to do with the amount of air that you can force from your lungs after maximum inhalation also. So see, it's important in diagnosing lung restriction, and in restrictive lung disease you have low um, forced vital capacity. Forced vital capacity is less than the lower limit of normal, and usually you use the software to predict the lower limit of normal based on the age, ethnicity, gender, and height also. Alright, so with the FEV1 and the um, forced vital capacity ratio, generally FEV1 FVC more than 70% in an adult is normal. So it's important in diagnosing airway obstruction. For example, airways smaller than normal. Yeah, so if you have for FEV1 FVC ratio of 0.75%, that's normal. With airway obstruction, forced respiratory volume 1 FEV1 is reduced, and the forced vital capacity may be normal or less reduced than the forced respiratory volume in the first second. So the FEV1 FVC ratio will be reduced. And yeah, so airway obstruction, you have low FEV1 FVC ratio. So FEV1 FVC ratio is less than the lower limit of normal, and generally the lower limit of normal in average adults is around 0.7, which is 70%, and software is used to predict the lower limit of normal, that's LLN, based on the age, ethnicity, gender, and height. Alright, so with forced expiratory flow, it measures that is 25% to 75%. It measures the airflow in the middle of a forced exhalation. Yeah, so F 25% to 75%. It measures the airflow in the middle of forced expiration. So it's measured from a segment of the forced vital capacity, which includes the flow from medium and small airways. So the forced respiratory flow of 25 to 40, 75% is an indicator of early onset small airway narrowing. Right, so let's quickly finish with some few interpretations. So with the normal spirometry, you know FEV1 FVC ratio more than the lower limit normal, or you could have a result where you have your FVC, that's forced vital capacity, or alone more than the lower limit of normal. So if you have the FVC more than that, then that's normal. If you have your FEV1 FVC ratio more than the lower limit normal, then that's the normal spirometry. But for restrictive pulmonary pattern or pulmonary conditions, you could have you would have your FEV1 FVC ratio more than the lower limit of normal, and your FVC, your forced vital capacity, less than the lower limit of normal. But with the obstructive pulmonary pattern, you have your FEV um, FVC ratio less than the lower limit normal, and then you have your forced vital capacity more than your lower limit normal. But there could be a mixed obstructive and restrictive pulmonary pattern. Here you have your FEV1 FVC ratio less than the lower limit normal, and you have your forced vital capacity also less than the lower limit normal. Alright, so if you have your FEV1 FVC ratio more than or equal to the lower limit normal, and you have your FVC more than or equal to the lower limit of normal, then yes, it's normal. If you have your FVC less than the lower limit normal, and your total lung capacity more than 80% predicted, isn't reached, it's less than the 80 predicted percent predicted, and you're dealing with a restriction. But if you have your if your FEV1 FVC ratio is less than the lower limit normal, and your forced vital capacity is more than the lower limit normal, then there's obstruction. But if your forced vital capacity is less than the lower limit normal, and the total lung capacity is also less than 80% predicted, then it could be missed or obstruction. Alright, so let's take an example where you have your forced expiratory volume in 1 second predicted as 2.28 liters, and the lower limit normal being 1.68 liters. So with this the forced expiratory volume in 1 second is above the lower limit of normal, and therefore it suggests that there's no significant airflow limitation. And with the forced vital capacity being 2.85 liters, and then the lower limit normal being 2.14 for the forced vital capacity, the forced vital capacity is above the lower limit normal, ruling out any severe obstruction. And with the ratio 81%, lower limit normal being 71%, the forced FEV1 FVC is above the lower limit normal and also within the normal range, so there's no obstruction present. So in an example like that, it's likely a normal spirometry. There's no significant restriction or no obstructive pattern. So let's take another example where you have your forced expiratory volume in 1 second being 1.19, whereas the lower limit of normal is 1.82, and you have your forced vital capacity being 1.7, the lower limit normal being 2.28. Your FEV1 FVC ratio being 70%, whilst you have your lower limit normal 70%. So this particular one, the FEV1 FEVC doesn't does not confirm obstruction, but wait, the forced expiratory volume in 1 second being 1.19, lower than the lower limit of normal, which is 1.82. It indicates there is a significant airflow limitation, but having the forced vital capacity lower than the lower limit normal, then that's restrictive. It could also be missed, and but with the FEV1 FVC ratio being the same 70-70, then it does not confirm obstruction. So with this, you could say it's a mixed obstructive restrictive lung disease, possibly, and possible restrictive pattern. Both the FEV1 and FVC have been reduced with the ratio preserved at 70%. So with a result like that, you need the full lung volume and DLCO testing to differentiate the pure restriction from the missed ones. Right. So another example. Let's look at another example where you have your forced expiratory volume in 1 second being 2.35 as compared to the lower limit normal being 2.41. So it's reduced. So you can think of reduced lower limits or possibly restriction. And when you take forced vital capacity, where you have your value 3.79, the lower limit normal being 3.01, then you know it's near normal, no significant change. But when you have your FEV1 FVC ratio 62%, which is below the lower limit normal, which is 70%, then you can think of an obstruction or obstructive lung disease. Alright, so you can finally make a diagnosis of moderate obstructive lung disease because there's reduced FEV1, low FEV1 FVC ratio, and increased FET. Right. There's also a possible small airway involvement because the EF 25 to 75% is mildly improved. Right. Criteria for reversibility with bronchodilator. You know that FEV1 change that's post bronchodilator and also pre-bronchodilator of more than 200 mils. And then if there's a change in the FEV1 more than 12% from the baseline, that is when you can see there's a tendency of reversibility. So FEV1 change more than 200 mils and the percentage change in the FEV1 more than or equal to 12% from the baseline. Alright, so with a pre-bronchodilator FEV1 2.0 and a post-bronchodilator FEV1 2.3 liters, you can see the change in FEV1, that is 2.3 liters to 2.0 will be 300 mils, which exceeds the 200 mils. and the percentage change in the FEV1, which is the change in FEV1 um, over the pre-FEV1 times 100%, and that's 15%. 15% is more than 12%, so it's reversible. Okay. So another example you can think of, if the FEV1, the pre is 3.0 and the post bronchodilated FEV1 is 3.3. So a change in FEV1 3.3 liters minus 3.0 would be 300 mils, which exceeds the 200 mils threshold. But when it comes to the percentage change, which is changing the FEV1 over the pre-FEV1 times 100%, if you have it 300 over 3000 times 100%, that is 10%. So though the change in FEV1 exceeds the 300 mils, but then the percentage change is less than 12%, so it's irreversible. So another example of spirometry value. So let's say you have your FVC 1.99 or 67% below the lower limit normal, which is 2.23, and your pre being 1.99, then it's suggestive of restrictive or even missed. And if you have a forced expiratory volume in 1 second, about 57%, and that's also marked reduction suggestive of airflow limitation. And your FEV1 FVC ratio 67%, which is below the lower limit of normal, which is 70%, and that one too indicates there's an airflow obstruction. So this particular result is indicative of a missed airway condition. You have to do further testing, like the diffusion capacity test and others, to if there's interstitial missed lung fluid, lung tissue suggested. With the low volume loop, the x-axis has to do with the volume, the total lung capacity will show over the residual volume, and the volume between the total lung capacity and the residual volume. So we're seeing, and the y-axis basically has to do with the flow. So that's why it's the flow volume loop, and the peak flow, peak expiratory flow is indicated over there in the y-axis, and the peak inspiratory flow is also indicated in this loop. Yeah, so basically the expiratory length is the first ascending part of the flow volume loop, links the maximum TLC, the total lung capacity, and the value of the PEF, the peak expiratory flow. So it depends on the expiratory effort and the velocity and the force of the expiratory muscle contraction, and on the lung elastic recoil and the patency of central airways. The second descending part of the FV and flow volume curve links the value of the PEF and the value of the residual volume, and is relatively effort independent, and it reflects the peripheral airway resistance and lung elastic recoil. With the inspiratory length, the inspiratory part of the flow volume curve depends on the airway resistance and the strength of the inspiratory muscles, and it's less influenced by the airway obstruction than the expiratory flow. Its reduction indicates airway obstruction from extrathoracic regions. The key points on flow volume curve, like I said, the PEF being the highest, followed by FEF25, and then FEF50, then finally FEF75, and below the inspiratory limb. That is for the expiratory limb. The inspiratory limb, you have your um, FVC and the RV, residual volume. Alright, so the key points on the flow volume curve, remember the TLC, total lung capacity, residual volume, and the forced vital capacity. The PEF has a peak expiratory flow, is the maximal expiratory flow achieved, and is a measure of the air expelled from the upper airways, that's the trachea, bronchi. The FEF 25 to 75 is the mean flow between the points FEF 25 and FEF 75. The FEF 25 is the maximal expiratory flow measured at the point where 25% of the forced vital capacity has been expelled, and FEF 75 is the maximal expiratory flow measured at the point where 75% of the FVC has been expelled. The maximal rate, when we talk about peak expiratory flow rate, is the maximal rate that a person can exhale during a short maximal effort, expiratory effort after full inspiration, and is measured with peak flow meters. So in patients with asthma, the peak expiratory flow percent predicted correlates reasonably with the percent predicted value for the forced expiratory volume in 1 second. So the peak expiratory flow provides an objective measure of airflow limitation when spirometry is not available. So when it comes to the use of spirometry in respiratory diagnostics, remember that in obstructive pulmonary disorders or narrow airway tubes like bronchial asthma, COPD, the spirometric pattern is that FEV1 FVC ratio is reduced, and FEV1 is reduced more than the FVC. And with restrictive pulmonary disorders, the small lung volumes of total lung capacity from restricted lung capacity, the FVC is reduced more than the FEV1. Okay, so the can think of conditions like interstitial lung disease, lung fibrosis, kyphoscoliosis. With the mixed obstructive and restrictive pulmonary disorders, it exists when both the FVC and FEV1 FVC are reduced, and both the features of both obstructive and restrictive patterns are present. Alright, so when it comes to the flow loop in health and disease, know that pulmonary obstruction in coving of the second part of the respiratory loop occurs, and PEF is reduced. For restrictive, the forced vital capacity segments between total lung capacity and residual volumes are reduced. So there are some indications for pulmonary function testing, like in the evaluation of pulmonary symptoms and signs, like in chronic cough, SOP, unexplained hypoxemia, and screening for asymptomatic disease like occupational exposure, chronic smoking, and also quantification of severity of respiratory disease, evaluation of response to therapy, for example, in reversibility of or airway obstruction with bronchodilators, monitoring drug therapy for drugs with sufficient significant pulmonary toxicity, for example, amiodarone, methotrexate, as opposed to post-operative assessments, like assessment for sustainability of lung resections, spine surgeries, hepatobiliary surgery. Alright, so there is a bedside test for pulmonary function, that's holding breath holding test of subrasis or cybrasis. So with this, there's a small um, breath breathing in and then out, and you hold the breath and counts for some seconds. If there are signs of air hunger, there's no more breathing. Yeah. So that is it's quite simple. Okay, so with this, you as a patient, you take a full breath and hold it as long as you can. So the normal is more than 25 seconds, which shows good cardiopulmonary reserves. From 15 to 25 seconds, that is limited cardiopulmonary reserves, and less than 15 seconds poor cardiopulmonary reserves, and requires further assessment for elective procedures or even surgery. And with breath holding times and capacities more than 25 seconds, the vital capacity is greater than 3.5 liters. From 15 to 25 seconds, the vital capacity is about 2.5 liters to 3.5 liters. And below 15 seconds, then the vital capacity will be less than 2.5 liters. Another one too is the match blowing test of Snyder. So with that, the procedure, a mouth wide open and the chin is supported. You let the patient open the mouth with no head tilting. And the match is held about 15 centimeters, about 6 inches distance, and the match stick and the mouth at the same level, no pairs lipped. You blow the match. If the patient is able to blow the match, then the FEV1 is more than 1.6 liters. If the patient is unable to blow the match, then the FEV1 is less than 1.6 liters. Other tests of lung mechanics, spirometry, like I said, is ideal for diagnosing obstructive pulmonary disorders and may be useful in diagnosing of restrictive lung disorders. And when the total lung capacity measures are not available, you of course need the spirometry. The flow volume curves may also diagnose intrathoracic or extrathoracic airway obstruction. With the lung volume measurements, for example, the total lung capacity or the FRC measurement using the body box, plethysmography be used. Yeah. So gas dilution methods like helium dilution or nitrogen washout may also be used in case of missed, whether obstructive, restrictive missed conditions. Alright, so DLCO, which is a diffusion capacity of lung for carbon monoxide or transfer factor, is used for assessment or assessing diffusion of function of lungs. That is in case of impairment. So it's impaired when diffusion distance is increased. In lung fibrosis, impaired if alveolar surface area is reduced, in emphysema or post-lung resection. And also arterial blood gas could be used, the measurement of oxidation, ventilation, acid-base status, and A gradients. Another test for cardiopulmonary interaction, 6 minutes walk test with 6 MWT, and also cardiopulmonary exercise testing. That could normally in cardiovascular cases too. Alright, so that is it for now. We'll continue with lung compliance soon.